Gynecologists have 55% of litigation cases out of these 5 to 6 cases every month. A retrospective analysis of judgments from district consumer courts in South India revealed that out of approximately 1,300 medical negligence cases, about 26% were related to obs and gynae, with negligence proven in 31% cases. What about the lay public? Well, the lay public is convinced through media that modern research has eliminated all the risks and hazards associated with childbirth. The general public thinks that delivery is a simple natural process thanks to their nannies and dadis, bereft of dangers and any complications. Any deviation from normal is considered as mismanagement by the doctor. So what is the prevalence of high-risk pregnancy in our country? Well, according to different studies done by Swami and Prajapati, the incidence of high-risk pregnancy has gone up in India, and the rate is almost 50% of all pregnancies. Cases against obstetricians are usually seen when there is a maternal death, a stillbirth, a neonatal death, cerebral palsy, or major congenital defects in the neonate. So what are the causes of litigation? The first and foremost is failure to identify a high-risk pregnancy. So we have to be alert on this point, most importantly. Failure to amplify monitoring and management for a high-risk case. Failure to communicate or poor communication to the patient and relatives of likely complications. Failure to take their consent regarding this communication. Breach of duty during labor, delivery, anesthesia, and of course, death of patient, fetus, or neonate, which is a big thing. Also, failure to detect fetal anomalies. Well, there is a notable case where a gynecologist and hospital were fined 17 lakh rupees for failing to detect a fetal anomaly despite multiple ultrasounds. Whereas in the United Kingdom, the Society of Fetal Medicine has passed an order where 11 malformations can be missed. So they have the doctors, they have the societies protecting the doctors over there. But in India, unfortunately, we don't have any doctor guild or any doctor society which protects the poor Indian doctor when in need. Well, what happens? Why do we undergo medical legal suits? Well, one of the causes is mismanagement during labor. Errors such as delayed cesarean sections, improper handling of cases like shoulder dystocia, breech twins, misinterpretation of fetal monitoring, all these have led to adverse outcomes and subsequent legal actions. Mismanagement during labor also, well, what can we do about it? Pre-identify high-risk pregnancies during admission to labor room, triage, and be in readiness to manage. So at that point of time, the patient comes into the emergency or to the labor room, then the patient has to be identified whether she's a high-risk patient or a normal risk. Keep the team updated with recent guidelines, conduct drills to organize role plays, be in readiness to manage. So, but also we must keep in mind that all pregnancies are at potential risk of complications during labor. What about postpartum complications? Very important because it's PPH which lands us into trouble. So negligence and delay in managing postpartum hemorrhage, where every minute counts, has resulted in litigation. So usually what happens is either the blood comes in late, or either we think that we can manage without blood or without giving IV fluids and all the rest of the management protocol that we need to follow. What can we do to prevent litigation? Well, timely detection of high-risk pregnancy. Not to be missed high-risk pregnancies are, of course, hypertensive disorders of pregnancy, gestational diabetes mellitus, recurrent pregnancy loss, bad obstetric history. We must take a very good obstetric history of previous stillbirths, preterm labor, PPH, congenital anomalies in previous pregnancies. Then if it's an IVF case, obesity, anemia, any patient who's above the age of 35, which we see so often these days, FGR, abnormal placentation, previous LSCs, multiple pregnancies, antiphospholipid syndrome, RH incompatibility, antepartum hemorrhage, cardiac disease, intrahepatic cholestasis of pregnancy, and the list goes on. So we have to have our antennas up whenever there's an antenatal case who comes to us, and we need to find out whether she's a high risk or not. What are the preventive measures which we can take to avoid litigation? Well, documentation, and documentation. Maintain detailed records of patient interactions, diagnosis, treatment plans, and informed consent forms. Adherence to clinical guidelines. Follow established protocols for managing high-risk pregnancies to minimize errors. We need to attend as many CMEs as we can, as many as these webinars as we can. And of course, there is Google, PubMed, and all the rest of it, the RCOG guidelines, the ACOG guidelines, which are available to us in a minute. So we must follow them. We must read them up. Regular training. Stay updated with the latest developments in obstetric care and legal requirements, most importantly. That's one area which we are lacking in. What are the risk management strategies? Implement hospital-wide policies to identify and mitigate potential risks in patient care, right from the time the patient arrives into the hospital, if she, from the guard to the emergency section, to the labor room, and the paramedic staff involved, the nurses in the obstetric unit, and the junior doctors. Everybody should know how to manage a risk and how to identify a risky case. Key sections of a high-risk pregnancy consent form. So what does the consent form actually should consist of? It should consist of patient information, which means the patient's name, the date of birth, address, contact information. It should contain the patient's medical history, the relevant past history, including conditions or known allergies. The pregnancy information should be mentioned, the gestational age, number of previous pregnancies, and any complications. The proposed interventions should be mentioned on the consent form, which is detailed explanation of the planned treatments, procedures, or surgeries, including their purpose, risks, and benefits. Alternative treatments after discussing with the patient the various options and their potential outcomes. All these should be on the consent form. When do we need a written consent form? Well, the indications are whenever we're doing an induction of labor, before a blood transfusion, before a cesarean section, which we always do, instrumental delivery, epidural anesthesia for painless labor, refusal of blood tests, ultrasounds, medication treatment, whenever the patient refuses certain things, like she wants to get an ultrasound done from a very, from some neighbor or somebody whom she knows, and she doesn't want to go to an expert. She doesn't want to get the blood whenever required. All these things need to be noted down. Then the permission to do a VBAC, there should be a written consent form in which we are actually trying to tell the patient that what are the risks involved in a VBAC. Then doing a manual removal of placenta or repair of severe perineal tears, all these need a written consent. What should be done to prevent litigation? Predict, and predict. Predict that you're going to have a problem. So prevent, and then prevent, prescribe, monitor such a patient, and deliver when the need, whenever required. So how we do that? Through intense monitoring, which is a totally separate subject. What are the warning signs which should be explained to the patient? When is she supposed to come to the hospital or call the doctor or come to the clinic? Well, the patient in attendance should be told verbally and in writing about the following symptoms. Whenever she has a headache which is persistent, blurring of vision, generalized swelling, pain in abdomen, blood-stained discharge, vaginal bleeding, watery discharge, reduced fetal movements, pain in the abdomen. Well, what is required from the obstetrician? Timely diagnosis and proper management of high-risk pregnancies. So timely diagnosis is very important. Then documentation. of the signs and symptoms on each antenatal visit, explaining, communicating to the patient and relatives the condition of the patient and the fetus. Every time she comes in for a antenatal visit, all these things need to be done. Documenting what is communicated, getting signatures of the patient and the relatives. Communication should be clear, effective, and empathetic. Ultrasounds like NT&B scan, level 2 scan should be done by an experienced sonologist. Emphasize that the detection rate of structural defects by ultrasound is only 60 to 70%. So whenever the patient comes back with a level 2 scan report, we need to add this sentence also, that ultrasound can only detect about 70% of congenital anomalies and not 100%. Effective communication, so very important. Ensure patients are well informed about their condition, treatment options, and potential risks. Well, there is an art of communication, and listening is an art. Let's become better listeners. So, listening indeed is an art. The art of communication is important not only for the patient to communicate with the patient, but also it helps us in our daily life, in all our relationships. The skill number one is non-verbal communication. So what is our body language telling the person who's sitting in front of us? Skill 2 is ask open-ended questions. So how were you the last 1 month? How were you in the last 15 days? Have you been taking, what have you been eating? Have you been exercising? All those kind of things, just to break the ice and also to find out how she's been doing. Then attention-giving gestures, like you're absolutely, focused on her. That is how we have to be. Reflected speech, empathy, avoid decisive or judgmental words. Very important. So avoid judgmental statements. Here is a situation to explain what is meant by judgmental statements. Deepa, a second gravita, 36 weeks gestation with previous cesarean section, calls a gynecologist late at night. Listen to the dialogue between the two. Deepa: hello, madam. Doctor says, yes. Deepa: ma'am, I'm having pain in lower abdomen since afternoon today. I'm feeling uneasy. The doctor's in an upset tone. You have pain since afternoon. You should have come to the clinic in the evening. These are lightening pains anyway, will subside gradually. Take the painkiller I prescribed last time when you had the same kind of pain. Come in the morning if pain persists. By the time Deepa was seen by the doctor next morning, the uterus was hard, tender, no fetal heart sounds. There was a rupture of the uterus with fetal loss. What else is required from the obstetrician? So that was one situation. Now we come back to what is required from the obstetrician. Timely and appropriate interventions. So we can't carry all our pregnancies to term or to 38, 39 weeks. We need to deliver sooner also in many high-risk cases. So we need to know all that. Adherence to guidelines. Keep photocopies of CTG recordings. Deliver high-risk patients in tertiary care setting, or timely transfer to such centers. Check for cross-match blood availability for all deliveries. Check neonatologist or pediatrician availability to tend all such deliveries. High-risk cases should be managed by senior obstetricians. Obstetric team should be well-versed in handling such cases. Treating obstetrician should guide the team of doctors and the labor room staff from time to time regarding the possible risks involved in each case. Collaboration and consultation, seeking inputs from senior specialists should be welcomed. And what else is required from obstetrician? Documentation and consents. Consents and documentation are the only weapons of defense in the court. Informed consent is mandatory for all procedures. It should include diagnosis with differential diagnosis, nature of treatment being planned and offered, risks involved with treatment, probable success rate, probable outcome of treatment if not carried out, respectful behavior, and good verbal communication by the doctor is important. And immaculate record keeping. Now, what is this quick response doctors team? This is also essential now in these days of medico-legal problems and mob issues. So we should make a group of doctors from approximately 20 hospitals, nursing homes, clinics working in the radius of 5 to 6 kilometers around us. Make and communicate through a WhatsApp group. Make a chain of doctors. So that is, if Dr. A foresees a problem, she calls Dr. B or Dr. C. So that is in the chain. It is the duty of these doctors who are next in line to alert and activate the rest of the group. All should try to reach the site. Numbers count. The more the doctors, the less the violence in the mob. Security services of good agencies should be taken, so the guards should be also very active, and police should be informed immediately. We should be the first ones to call the police and not the patient's relatives. Call 112. That is the number for police. It is good to have a liaison with the beat officer of our area. The doctors group should protect, escort, talk to the mob. So what does the doctors group do? Which comes over? It protects the doctor. The doctors escort the doctor to wherever, talk to the mob, help in documentation, help in transfer patient to tertiary center if need be. So the mantra is stay united to save our race, our race of doctors. Above all, tender, loving care is very important. Here's a case of placenta accreta spectrum. Gravida 2 para 1 with previous LSCS underwent LSCS at 38 weeks of gestation and delivered a healthy 2.8 kilos baby. As placenta was not expelled spontaneously, manual removal of placenta was tried. Patient started bleeding excessively from the placental side. Cross-matched blood was requested for, but took time to reach. Patient was operated in a nursing home with limited facilities. By the time blood arrived from the blood bank, patient had lost considerable amount of blood. A surgeon was called for help. Anesthetist tried to manage the case, wanted to shift the patient to a higher center. Meanwhile, the patient went into hemorrhagic shock. Obstetrician could not go ahead with obstetric hysterectomy, as anesthetist refused to manage the case alone. Soon the patient succumbed to PPH. Lessons learned. All cases of previous LSCS, myomectomy, DNC, placenta previa should have an ultrasound and also a TVS, barring the placenta previa case, at 35 to 36 weeks gestation to rule out placenta accreta syndrome. Cross-match blood should be readily available. Such high-risk cases should be managed in tertiary care centers. So this was just an example of what should be done. There's another case, Matthew versus Dr. Kalai Chelvi, May 2015. During antenatal visits, gynecologist Dr. Kalai Chelvi advised the patient to get an obstetric ultrasound scan done. Scan at 13-14 weeks, that is the NTNB scan was done by the ultrasonologist. Gynecologist told the patient that no congenital malformations were detected as the NTNB scan report showed. Then another scan was advised, the level 2 scan at 19 to 20 weeks. Again, the gynecologist stated no congenital anomalies after seeing the scan report. Patient delivered a baby with major congenital defect of hemimelia with absence of left forearm. The patient and family filed a suit stating intense trauma and high expenses for prosthetic arm and the added trauma of looking after a physically challenged child for lifetime. Both gynecologists and ultrasonologists were well qualified. During the argument in the court, the doctor stated that an amniotic band formed later on can lead to such a limb amputation anytime post level 2 scan. The judgment went in favor of the doctors. So the lessons learned: NTNB scan and level 2 scan should be referred to experienced ultrasonologists of the area. It should be emphasized that only 70% of anomalies can be detected. So in the end, I'd like to say you're stronger than you think. Thank you so much for your patient hearing.